Hi, my name is Dr. David Rubin. I'm from the University of Chicago. Welcome to this special program. On behalf of CME Outfitters, it's my pleasure to invite you and to welcome you to the program that we've put together for patients called Who's in Charge, You or Your Crohn's Disease? For the next hour, I'm really looking forward to a conversation with my very good friend, Dr. Bruce Sands from Mount Sinai Hospital in New York City. Dr. Sands and I will be discussing management of Crohn's disease and, very importantly, an update on new guidelines that have been published related to the management of Crohn's disease. We both feel that it's very important for patients to understand these guidelines and certainly to understand the advances that have occurred in managing Crohn's disease so that you can take charge of your Crohn's disease, or if you're a loved one who has a family member with Crohn's disease or someone that you care about, you'll understand how to support them. And we hope that you'll find enough information during this program to have an informed conversation with your healthcare team and the people who are managing your Crohn's disease when we're finished. Okay, so let's keep moving on. We have some more things to talk about. So we already mentioned briefly in your goals, Bruce, that symptoms and control of inflammation are both important. So let's get into this a little bit more and think about some of what we should know. So take us through why symptomatic remission is not enough and how patients should be explaining this, and maybe also what they should be asking their care team to better get control of the situation.
Right. So we said this in brief already, but I think I estimated 30% of patients in symptomatic remission still have persistent inflammation, but some estimates actually show it to be much higher. It may be as high as 75%. It probably depends a little bit on how we're defining inflammation. So that tells you could feel really well or relatively well, and yet the disease is still active on the inside. The disease process is not ultimately controlled. And we know that when people have ongoing inflammation in the bowel, there is a much higher risk that they're going to have symptomatic relapse over the coming year or two. So the implication, conversely, is that if you can control the inflammation, you may prevent that relapse. When we talk about mucosal healing, we're talking about healing of the inflammation of the bowel lining. This is typically what we see if we're looking in by colonoscopy and we're evaluating the disease that way. But we can also evaluate through imaging of the abdomen, such as with a CAT scan or an MRI. But that's really what we're looking for. It is a measure of the activity of the disease that is most directly involved with the disease process. And we now have evidence that in real studies that show that if you can achieve mucosal healing, that actually lowers the risk for relapse and surgery, and that's the goal.
So I'm sure that people listening to this who are symptomatic are wondering about how much inflammation there is. And those who may be feeling okay might now be worried that they're inflamed. So you mentioned CT scan or MRI, colonoscopy. Are there other things that we can do to know whether someone's inflamed that might not be as expensive or invasive?
There certainly are. None of them are totally perfect, but as a cheaper, easier way of getting at whether the inflammation is controlled, we can measure things in the blood. For example, we can measure C-reactive protein. We can measure something called ESR, or erythrocyte sedimentation rate. Those things are not perfect. They are not always elevated in people who have real activity of their inflammation. And in fact, maybe 20 or 25% of patients, people in general, don't make C-reactive protein and can't express it at all as a marker. But more directly, we can measure things in the stool. And I know patients don't like giving stool specimens. Who does? But there are things that we can measure, such as calprotectin in the stool, which would be a much more direct measure of inflammation in the bowel. Again, none of these things are perfect, but they're reasonable surrogates.
Okay, so our patients and their family members should be asking about ways to know if they're inflamed and to monitor that over time. What about the opposite, though? What about patients who are symptomatic and then they have these tests all done and there's no inflammation? Does that happen? And in your experience, how often, and what might be the cause of their symptoms then?
That certainly does happen, that people have symptoms and they have no evidence of inflammation either on these blood or stool markers, and sometimes even when you look in by colonoscopy or you do a scan, there's no inflammation. And there could be a variety of explanations for those patients who have symptoms that haven't gone away even though everything is demonstrably healed up. And that includes everything from kind of residual irritability of the bowel and symptoms from that, even after the inflammation, and that's a pretty common occurrence. It could be if you've had surgery that you are not absorbing the bile salts that normally would be absorbed by the last part of the small bowel that may have been removed, and that can cause some diarrhea, cramping, and irritability. And we also know that if you have any added anxiety or depression, that will tend to magnify even minor abdominal symptoms and make you feel more symptomatic. So it's important to get that treated too if that is a problem.
Right. So the point is careful investigation and considering other things that you've nicely outlined. One of the challenges in Crohn's disease, and I'm sure people can relate, is pain. And pain can be from different causes. Of course, we worry if there's an abscess or an infection, or if there's a bowel obstruction, or if there's inflammation that's irritating the organ around it or the lining of the abdominal cavity. But then there's lots of other things that we should be carefully investigating, whether it's a side effect of medicines, whether it's a kidney stone. It requires a careful evaluation and directed therapy.